Dear colleagues, it's my great pleasure to welcome everybody to our Case Reports in Ophthalmology Annual Meeting 2025. This meeting is organized by Foundation Ophthalmology 21, the University of Varmia and Missouri, and company MAC 21. We are happy to have sponsors to this meeting. I would like to highlight the impact of Magnapharm, Polpharma, and OCO Educational Foundation. We have also media patrons, the ophthalmologist. This is the global but UK-based ophthalmic magazine, Przegląd Okulistyczny. This is the Polish review of ophthalmology, very active ophthalmic magazine, and Medycyna Praktyczna, the largest medical platform in Poland. We'll have two sessions. The first session, Enigma cases, that will be chaired by Dr. Agnieszka Kudasiewicz-Kardaszewska from OCO Group. And as you see, she will be supported by many co-moderators. And then we have a lot of very good cases from the OCO Group. And the second session, during which we listen to interesting cases both from Poland and from Philippines, and we will be supported also by Dr. Kakampañ from Philippines, as every year, as a matter of fact, and also Dr. Kardaszewska as a co-moderators, and we will have very interesting speakers here. As every year, we have the opening lecture named after Ksawery Gałęzowski. Ksawery Gałęzowski, and here you can see the former Gałęzowski lecturers, including Professor Francesco Bandello from Italy, then Professor Ningli Wang from China, then Professor Stephen Schwartz from Bascom Palmer, Miami, and last year, Professor Ferenc Kuhn. I don't think I need to introduce all of them. They're well recognized. Ksawery Gałęzowski, he was assumed to be one of the best practitioners at the turn of 19th, 20th century in ophthalmology. He was a pioneer of ophthalmoscopy and the diagnosis of central nervous system disorders. He coined the term cerebroscopy. He also introduced ignopuncture, so cauterization of retinal ruptures after evacuation of subretinal fluid in retinal detachment treatment. He was a Pole. However, he spent majority of his life abroad, mostly in Paris, where he became a very highly respected doctor, ophthalmologist. He was very productive, as you can see here, with about 300 articles, 12 books on nearly every aspect of ophthalmology. He also was a tutor to many French ophthalmologists, including Perrineau, and he founded the first French monthly ophthalmic journal, Journal d'Ophthalmologie, and he also constructed several ophthalmoscopes. As you can see here, this is a packet ophthalmoscope, this is a tubular ophthalmoscope. So he was a very interesting, productive ophthalmology creative. Today, it is my great pleasure and honor to introduce this year Ksawery Gałęzowski lecturer. It is Professor Michael Repka from Johns Hopkins University School of Medicine, Maryland, US. He will speak on amblyopia outcomes in real-world practice. Professor Michael Repka, as I mentioned, he is related with the management of strabismus and amblyopia, and he was a former chair of the Pediatric Eye Disease Investigated Group, and also a former president of the Maryland Society of the Eye Physicians and Surgeons. He's also a medical director of government affairs for the American Academy of Ophthalmology, and presently he is the president of American Academy of Ophthalmology. So we are very proud and happy to have his lecture at our conference this year. Please listen to the lecture now.
Hi, I'm Michael Repka, David L. Guyton and Fudiniak Family Professor of Ophthalmology at the Wilmer Eye Institute in Baltimore, Maryland. I'm going to speak about amblyopia outcomes in clinical practice. I'm a consultant to the American Academy of Ophthalmology and have no commercial interests. As this is a conference on case reports, I'm going to present a 9-year-old boy, failed vision screening in 3rd grade, negative personal and family history for ocular or medical diseases, and has 2 normal siblings with normal vision. He's had normal development, and his vision on presentation was 20/20 in his right eye and counting fingers at a few feet in his left eye. The pupillary reaction was normal, color vision was normal, the optic nerves and the remainder of the anterior and posterior segments were normal, thus not likely an optic neuropathy. There was no nystagmus on stereo, was 3 of 10 Randott circles. Cycloplegic refraction was highly anisometropic and no improvement in trial frames with cycloplegia. So glasses were prescribed and worn for 3 months. He returned best corrected vision 20/20 and improved to 2200. But this treatment was simply at the practitioner's best judgment. What is reasonable treatment in 2025? We might base that on case reports or opinions or case series, clinical trials, although this is a relatively unusual problem, consensus guidelines such as the AAO's preferred practice pattern, and real-world evidence. So in this talk, our objectives are to define amblyopia and review the outcomes for amblyopia treatment using IRIS registry data. Amblyopia, as I'm sure we all know, is a deficit in high contrast, best corrected visual acuity. It is a neurological condition with structural changes in the brain demonstrated more than 50 years ago. It is due to disruption in the visual experience of a young child. It is most often unilateral, but can be bilateral. It also includes impairment of binocular depth perception, as in our patient. Visual motor functions can be abnormal. Binocular reading speed, motion detection, vernier acuity, and fixation stability have all been shown to be less than normal. There's also a reduced self-perception of acceptance and physical competence in the world. Even if the visual acuity deficit is corrected, many of these negative impacts persist. In terms of quality of life, at a mean age of 67 years, occupations did not differ by with or without amblyopia. However, fewer amblyopic individuals completed higher university degrees. Similar education attainment and jobs performed, but no predisposition for workplace injury in a study from the UK. But in a study from California using US claims data, there was a 12% increased risk of musculoskeletal injury, fracture, or fall in adults with amblyopia. The prevalence has a worldwide estimate of about 2.4%. Estimates are slightly less in the US, a little bit less in African American than in white children. Similar rates from 1.9 to 3.6% have been found in Australia, Europe, and the United Kingdom. In terms of cause, refractive error, strabismus, refractive error and strabismus, or deprivation are the most common. Population-based studies have shown that refractive error is most common. That's 70% in IRIS data, VIP or Vision in Preschooler study, and the MEPEDS-BPEDS study, prevalence studies of eye disease in Los Angeles and Baltimore, respectively. Clinic-based studies, of course, are very different. Strabismus is overwhelmingly the most common, nearly 60% in PEDIG trials, 83% in a review John Flynn did in 1998, and an earlier study for the UK also found strabismus associated in 84% of cases. So I wanted to look in this study about amblyopia in the IRIS registry. The IRIS registry is a clinical practice database which is extracted from electronic health records, so it does not require manual extraction. 11,574 ophthalmologists using 3,000 practices using integration of their health records in 2019 were involved. 427 of those physicians were self-designated pediatric ophthalmologists. In IRIS registry at that time, there were 71 million patients. 1.7 million of them had an amblyopia diagnosis, and you can see that distribution from age birth through age 90. So a lot of patients reported in the first 20 years of life, as you would expect, and then a surprising peak during Medicare age group in our country, 65 to 90. The overall prevalence is 2.47% in the overall group, similar to the population-based estimates, 9.92% in children, 1.68% in adults. Interestingly, there is a left eye predominance of amblyopia, statistically significant, but a 5% difference in young patients and nearly 9% difference in older patients. By cause, as I mentioned before, refractive causes were the most common, and if you combined, you can see the 70% figure in birth to 18 years and roughly 55% in the greater than 18-year-old patients. So a snapshot of what happened in these patients. So in IRIS registry, the patients are followed longitudinally, but they don't come in on a set schedule, but follow the schedule that the clinician prescribes. And in this cut, I've taken 4 groups of those patients. So 45,000 children, 3 to 6, and 58,000, 7 to 12 years of age, and so forth, and looked at their visual acuity at the first visit and at the last most recently reported visit at IRIS. We assume that they were treated in that time period if they were eligible for treatment or followed. So it gives us an overall sense of what's happening to visual acuity. In row 2 and 3 are the logMAR visual acuities at each of the time points for each of the groups. The mean improvement was just under 2 lines for the young children, something that we've come to expect as an average improvement in amblyopia. Just under 1 line, surprisingly, for age 7 to 12. Those improvements took, on average, or were measured over an average of 2.5 years. That probably reflects the longitudinal follow-up we had at the time of this project. But as you would expect, improvement is certainly better in the younger children, but importantly to our child here, a line of visual improvement is possible on average. If we take the data and cut by the age, so these are bins of 1 year of age from 3 to 17 years, the baseline amblyopic acuity is in orange, and the last or follow-up visual acuity is in turquoise. And you can see for nearly all of the boxes, all of the ages, you can see that there's a shift toward improvement. Now, some of this is true improvement. Some of this, I assume, could be better refraction, or some of this could simply be learning effect or age effect. Although you wouldn't expect much of an age effect after the age of 6 years in this population. But you can see that in clinical care, the patients do improve. What about the fellow eye? This gives us an idea of what the learning effect or age effect might be. And you can see that in similar time points, baseline orange, most recent in turquoise, the younger children do improve in their fellow eye. So up to about age 7, you see that improvement. But after that, there's really no learning effect overall. You can also see that there are a whole bunch of outliers in terms of the resultant visual acuities and starting visual acuities. What about the deficit? Do we ever clear visual acuity? This is really important to deciding, am I a success or is my patient having a success or failure? So these are the fellow eye, so the good eye in orange and the amblyopic eye in turquoise. And you can see that for all age ranges studied, even though we had improvement of 2 lines under 6 and 1 line from 7 to 12 and half a line above 12, every time point, we're not close to the means hitting each other. So a permanent deficit of 0.8 to 2.4 lines seems to be the norm in what we're achieving in routine practice. So how can we use these data to improve outcomes? Well, we need a benchmark to assess our performance in our prescribing, in our ability to get the parents to do what we'd like them to do with their child. And there could be many benchmark measures developed. One measure developed by the pediatric ophthalmology community in the United States was IRIS 50. So these are a series of outcome measures that are part of the IRIS data registry that are automatically calculated for eligible patients. For this measure, we took children more likely to succeed. They had to have a baseline visit, of course, and a second visit somewhere in the 3 to 12 months later in the same calendar year. Now, that's a little odd, but that was because of our regulator telling us that they wanted to be able to measure in 1 year, like they might do with cataract surgery outcomes, where you can do it in a few weeks. Unilateral amblyopia, deprivation care excluded, and any clinical care was allowed. The measure says, I'm a success for this treatment if my patient improves 2 or more lines. I'm a success if my intraocular visual acuity difference is 2 or fewer lines. I improve to 3 or more Snellen lines, or final visual acuity 23 or better. So it improves the chance of being considered a success on this benchmark when we use the OR connector. So when we apply that to IRIS registry, so we took those children, took the subgroup from 3 to 7, and there were just under 19,000 children who are really going to set our benchmark. The success rate for 8 to 12-year-old, for 3 to 7-year-olds was 77%. Good, but obviously there's some room to improve. Incidentally, for 8 to 12-year-olds, that was 55.5%. So we had a lot of improvement still in that group. That's really important to know. If we look at IRIS registry and compare it to other studies, so IRIS registry, 77% for that 3 to 7 years of age group. The ATS-1 study, that was atropine versus patching for the same age group, that success in a clinical trial was 83.5%. So clinical practice, not quite as good as clinical trials, but that's very standard in our field. And Boston Children's applied the data retrospectively to their own practice and found a success rate of 81%. So you can see that all of these studies suggest we're doing okay, this is what I should be targeting, but our world should still be working on studies to improve. When you have data samples so large, you're able to look at other variables. And so in multivariable analyses, girls did as well as boys, or said the other way, boys did as well as girls. Sometimes that's been an anecdote that's not true. White children in our country compared with Black African American children did better. So the odds ratio of success was lower for Black and African American children significantly. It was lower but not statistically significant for Hispanic or Asian children. Similarly, we looked at the odds ratios for insurance. Medicaid is a government-provided insurance, so for lower socioeconomic groups, and those children did 29 to 40% less well on average if we look at that confidence interval. Interestingly, children on Medicare in our country, there are a few, usually they have other disabilities, and they also did more poorly, although not statistically significant. And then military insured children did about the same as commercially insured children. So registry research has its limitations and the benefits of being able to benchmark to look at regular care. But there can be coding errors. There could be an incomplete treatment course due to the measure specification. The visual acuity measurements were not standardized, and the measurements were performed in habitual correction in clinical practice. We can't compare treatments because we don't have in IRIS Registry yet the ability to extract what treatment was done, and it's not in ICD-10 or 11 coding. There may be missing data. Treatment, of course, was at prescriber discretion and familial compliance. And we cannot comment on children who are not accessing care. These outcomes are for those children in care. So in conclusion, treatment success was about 77% for younger children and 55% for older children. Similar to other studies, but these represent reasonable benchmarks for clinicians and for treating our 9-year-old patient. Black and African American children were less often successful. Government insurance for lower socioeconomic groups was reduced, and a large proportion of U.S. children continue to have disparate outcomes in their amblyopia treatment. So we have a residual deficit of 2 lines on average. We need approaches for detection and treatment that will improve. We need to keep working on it with new strategies for reaching and treating children, as well as advocacy and funding. Thanks very much for your attention, and have a great rest of your meeting. Incidentally, our child here continued to improve, but peaked around 2060 minus. So improved a number of lines, as you might expect, but was not a complete success because of the delay in detection.
Dear Michael, dear Professor Repka, it's so good to have you with us, and we use this opportunity for a short discussion, even if it's not scheduled in the program. But since you are with us, we have a few questions, and we will try to use your presence with us. So if you don't mind, we'll keep you a bit longer, just a few minutes. So at first, thank you for this very educative presentation. Regarding questions, Agnieszka, because you started sharing some questions at the chat, maybe you can put the questions by yourself.
Okay. So how about isoametropic amblyopia, when you have in both eyes errors and there is an isoametropic problem, how to treat these children, occlusion of the either eye, and how long? And the second question, how long to occlude better eye per day in order not to create amblyopia in the better eye? So 2 questions.
Sure. So wonderful questions, of course, and thanks for the opportunity to be here. With respect to isoametropic amblyopia, those aren't in the IRIS data. I would say that our PETA group did study isoametropic children, but it was simply a glasses-only treatment. We didn't do alternate patching, but they almost all got better over about a year of wearing glasses. So at least for the moment, the standard treatment for isoametropic amblyopia is get the right correction on them. Now, if there's a microstrabismus in there, then there might be a reason to do some additional patching. The other question about how long to patch, of course, has been a generations-long debate from every waking moment to what we might have called homeopathic treatment dosages. And I would say we don't know for sure, at least our clinical trials suggest that 2 hours is adequate for most children, but not every child. And it's an okay place to start, but one should be willing to increase the dosage if they're not improving. We tried that in one trial and, did the regular 2 hours of treatment, followed the children until they stopped getting better, and then randomized to increasing dosage. And both groups, the increasing dosage group and the stay at the same dose, continued to improve. The increased dosage group did a little bit better, but one of the problems in amblyopia research continues to be the rate of progression of improvement. We are not, we don't have great sensitivity, particularly in young children, because of the whole line measurement. And because the steps are whole lines for children under 7 years of age, we do lose a little bit of our sensitivity. And we just have to remember that. With respect, I saw another question in the chat, but I think I'll wait until that's posed.
Oh yeah. This is the question about the digital technologies. Yeah. As we know, in recent years, there are appearing some studies showing the effectiveness of digital technologies. But the question is, are they better than occlusion? Do they bring any benefit for us?
One wonderful question, and I'll just make sure two disclosures. One, I was the medical monitor for the Luminopia gadgets treatment, and PDIG is doing a number of trials with both CureSight and with Luminopia at the moment. And I don't know the answer, but it's what every regulator now asks when they ask about coverage. Even this week, I was on the phone with some medical directors for a large U.S. insurer, and we don't have those data. Superiority data don't exist, at least there's not enough superiority data that is compared to patching. There is a trial with CureSight, of course, but one trial does not a technology make. I think that for many of us, superiority has been less of the scientific question initially. It was to see if it worked at all. And that, I must admit, that's how the early trials went. And that's what the industry had to do to get licensing approval in the United States. And they weren't going to push for superiority. I think as clinicians, we'd love to see superiority because then it would be a first level treatment. Today, I think that if the average payer or family is going to say, well, let me try the inexpensive treatment first, and if it fails, I'll do the more expensive treatment. I think that market is still sorting out. So I don't know the answer there. You would think it is an important clinical question. It's just not established.
Yeah. Thank you so much. This was the last question. We need to move on with the conference. I would like just to maybe add that with Professor Repka, we have organized for, I don't remember how many years, but a few, a session on myopia at American Academy every year. Sometimes in person, sometimes it is on virtual or demand like this year, but hopefully next year we'll be able to organize it again and then of course invite everybody to join our myopia session at AO next year.
Yeah, so you're to be congratulated for bringing that topic to the American Academy of Ophthalmology meeting when no one cared about it. Today, we're in a very different place in terms of myopia control around the world.
We started many years ago, I think 10 years ago, something like that. Yeah,
indeed.
Exactly right. Nobody really predicted that at that time. Yeah. Thank you so much again. And now we will move on with our pre-recorded presentation that belonged to the session one, please.
Ladies and gentlemen, I am grateful for the invitation. I would like to present the Enigma case, mysterious uveitis following vitrectomy, and opening the question, why did this happen and what to do next. We will go back in the end of the presentation to this. This is the case of 71-year-old Caucasian male with gradual vision deterioration and black floating object in front of his right eye. Here is the fundus photo. You can see the floaters. 1.5 years before, his right eye was hit by the ball from ball gun with subsequent intravitreal hemorrhage, which was left untreated, and the floaters are probably the remnants of it. He was taking ocular drops for mild glaucoma, but he was not totally compliant to it. Main complaint was the vision like a fog with aggravating metamorphopsia in the right eye. This is his left eye. You can see a membrane. In the first visit, we discovered metamorphopsias, visual loss in the right eye to 0.3. Left eye was 0.8 with no metamorphopsia. Patient knew that he had a cataract and wanted to have the best IOL in the world. This was small cataract in the right eye, in the posterior segment, and also some cataract in the left. But you could see in the OCT, both eyes had a epiretinal membrane with fovea distortion and mild glaucomatous damage, the slightly elevated pressure. So we decided to do phaco-vitrectomy with the monofocal lens in the right eye. In the left, might need some surgery, and we decided to monitor his glaucoma. After the operation, do perimetry, OCT, and probably laser treatment. This was the plan. So operation went well, vision went up, so it improved. And 6 weeks post-operatively, the patient looked like this. Clear vitreous cavity, no epiretinal membrane, normal retina attached, macula almost normal, although slight, still some fluid under the retina and elevation of the fovea, but the vision went from 0.3 to 0.6. The pressure, it was 16, so he was left on timolol twice daily and scheduled for left eye operation, and we decided to discontinue slowly steroids and non-steroidal anti-inflammatory drugs. But 2 weeks later, when everything was stopped, so 8 weeks after operation, a patient showed up with painless visual deterioration and fogging. The vision was 0.05. Right eye was little pink with Tyndall on plus, iris blurred, IOL coated with fibrin, and visibility of the fundus was reduced. So macular edema and subretinal fluid was noted in the right eye, and also macular edema on the left. The pressure was high and on medications. So all medications except for timolol were discontinued 2 weeks before. And right now we did pressure lowering overload. So we did acetazolamide, mannitol, timolol plus dorzolamide. Uveitis and lab tests were scheduled, and left eye surgery was, of course, postponed. And tests showed up that patient was HLA-27 positive. So what was the next step? First of all, we went back to history. Patient recalled that he had the episode of iritis 3-4 years before. No tests were done. We decided to do revitrectomy with cleaning of the anterior chamber, intraocular lens, and posterior chamber. The vision after this surgery went back to 0.8. You can see the clear fundus appearance and almost back to normal in the OCT. Patient had quite good pressure, but on timolol, dorzolamide, and brimonidine. The problem was that he was non-tolerated to acetylzolamide, Lotemax, taflotan, and monoprost. The vitrectomy in the right eye was done in general under general steroids. Post-operatively, steroids and antibiotics were kept for a longer time with slow tapering because we were afraid of recurrence of the uveitis. So in conclusion, we have to always remember that taking a detailed history when something strange happens is sometimes or is actually crucial. Any episode of uveitis needs diagnostic tests to at least trying to establish its cause. But my open question is why it may happen and what to do with the other eye. Shall we go for vitrectomy, go for phaco or phaco-vitrectomy, and how to treat his glaucoma? Thank you for your attention.
Not everything that appears typical is truly age-related macular degeneration. Not every subretinal hemorrhage is due to neovascularization. That will be a case report. A 78-year-old patient admitted due to worsening vision in the right eye, image distortion for 10 days, best corrected visual acuity 0.05. Fundus photography showed a hemorrhage in the macular area, and OCT scan showed macular edema. On the day of presentation, the patient received an intravitreal anti-VEGF injection of faricimab. 2 days later, Actylis and gas were administered via pars plana. At the 2-week follow-up, best corrected visual acuity in the right eye was 0.3. We can see absorption of the hemorrhage and the reduction in macular edema. Subsequently, 3 additional anti-VEGF injections were administered, 2 with bevacizumab and 1 with aflibercept at monthly intervals. An improvement in visual acuity was achieved along with further absorption of the hemorrhage and a reduction in retinal edema. Best corrected visual acuity was 0.5. After the treatment, a vascular abnormality, a macroaneurysm of a branch of the central retinal artery, became visible at the site of the previous hemorrhage above the fovea. It was decided to perform focal laser treatment around the macroaneurysm. Follow-up examination 3 weeks after the laser procedure. Best corrected visual acuity 0.6. Fundus photography showed retinal laser scars and there is no macular edema on the OCT scan. In conclusions, not all subretinal hemorrhages are attributable to neovascularization in the context of age-related macular degeneration. Careful evaluation of the fundus following hemorrhage absorption, as well as assessment of the fellow eye, is essential. In this case, As we can see on the fundus photography and OCT scan, no changes typical of age-related macular degeneration were observed in the second eye.
Good afternoon. My name is Małgorzata Ozimek, and I would like to present a case analysis from the Professor Zagórski Eye Surgery Center in Nowy Sącz. The title of the presentation, May the Intuition Be With You. Additional tests can sometimes mislead us. A 72-year-old female patient was referred to our clinic for bilateral cataract surgery. Medical history included multiple myeloma treated with iberdomide, an immunomodulatory agent, and dexamethasone. Baseline best corrected visual acuity was in right eye 0.4 and in the left eye 0.4. Intraocular pressure was normal. Slit-lag examination revealed nuclear cataract in both eyes. The fundus was described as a normal with additional remark irregular retinal coloration. The patient underwent uncomplicated cataract surgery of the right eye. Postoperatively, standard topical treatment was prescribed, Ducressa 4 times a day and yellow 2 times a day. At the postoperative follow-up, the patient complained of no improvement in vision. Best corrected visual acuity remained the same in the right eye, 0.4. Slit lamp examination of the right eye showed proper wound healing, no signs of anterior segment inflammation, and a correct positioning of the intraocular lens. However, the fundus appearance became concerning. In right eye, along the superior retinal vessels, we observed fluffy white lesions, and in the left eye, peripheral temporal granular yellowish lesions, larger than in the previous examination. We suspected vasculitis, retinal vasculitis. The patient was urgently referred to an ophthalmology department with the admission arranged for the following day. The differential diagnosis of retinal vasculitis, in this case phlebitis, of course is broad. However, considering the patient's age and the anterior and posterior segment findings, the differential could reasonably be narrowed down to severe diseases. Patient returned to our office approximately 1 month later. During hospitalization, she underwent serologic testing for Borrelia, cytomegalovirus, Epstein-Barr virus, HIV, and toxoplasmosis. All tests were negative. Patient was discharged on oral corticosteroids with diagnosis ischemic changes related to oncology treatment. Patient complained for progressive visual deterioration. Best corrected visual acuity was in right eye 0.5 and in left eye 0.4. In slit-lag slump examination, anterior segment was normal. However, we still observe changes in fundus. In right eye, above the superior eye-cut, ischemic atrophic changes at 2 o'clock, periphlebitis more pronounced than previously. In left eye, progression of lesions, periphlebitis temporally and along the anterior arcade. Given the active inflammation with features highly suggestive of viral retinitis, we contacted the patient hematologist. Serology in such cases can indeed yield false negative results, and PCR testing was recommended. PCR confirmed cytomegalovirus infection. It is important to remember that multiple myeloma, the disease itself, impairs immunoglobulin production, and immunosuppressive therapy further reduces the body's ability to mount an antibody response. The patient was again urgently referred to hospital to initiate appropriate treatment. During second hospitalization, this time in another center, patient was initially treated with acyclovir without improvement. Treatment was then switched to ganciclovir. She is currently on oral valganciclovir and metyloprednisolone. At the post-hospitalization follow-up, visual acuity had worsened to 0.1 in the right eye and 0.05 in the left eye. Slit examination showed In right eye, anterior segment was normal. In left eye, we observe cataract progression. Fundus findings: in both eyes, we observe regression of active lesions. In right eye, superior retinal thinning, and in the center, fibrosis causing increased retinal thickness. In left eye, temporal foul peripheral retinal thinning, in mid-periphery and inferior arcade areas with pale lesions of blurry borders. Macula was poor visible. Treatment was continued, and we decided that after stabilization of inflammation, cataract surgery in the left eye will be performed. In cases with a high risk of vision loss, we must act rapidly and precisely, from initial diagnosis through hospitalization to appropriate diagnostic workup and treatment consistent with current standards. Close interdisciplinary cooperation is essential. Unfortunately, this case exposed several systemic deficiencies. To conclude, let me quote my favorite neuro-ophthalmologist, Dr. Andrew Lee. "If it quacks, it must be a duck, so don't be misled by false negative results." Thank you very much for your attention.
Ladies and gentlemen, thank you for inviting me to this wonderful conference. I will be talking about retinal detachment, and this is the case of an 18-year-old girl. She's now 18, but she was diagnosed as retinoschisis and RD in October 2021. This is the appearance of her right affected eye, and this is the other eye with full vision. The right eye was 0.05. General, the health was good. This was the OCT. You can see the traction lifting the retina. To eliminate the traction and hoping that we can treat this RD, vitrectomy with laser around optic disc was done. And diagnosis established back then was retinal detachment related to optic pit. Here you can see the fundus appearance after operation and OCT. Vision was 0.1. But between 2023 and 2025, she had visual acuity decline, and it was decline and then improvement, decline and then improvement. And here you can see the first picture here. This is from 2023, and this is for 2023, and this is 2025. And in June 2025, the vision was 0.2, but you can see almost no detachment, and the OCT, the retina, is in place. But in November 2025, again, visual acuity decrease, 0.05 the vision, and again, you can see the recurrence of this tractional detachment with subretinal fluid and the optic pit, which is probably not close. And the vision causes depression with suicidal thoughts of the patients, so it has to be addressed really seriously. So my question to the audience is what to do next? Because optic pit seems still to be open, so shall we do laser around the disc, or maybe micropulse laser, or maybe revitrectomy with gas? I will be very grateful for all suggestions. Thank you for your attention. Ladies and gentlemen, at the end of our Enigma session, I would like to present our weird clinical cases from the medical center in Nowy Sącz. The first one, it was a 50-year-old patient treated for primary open-angle glaucoma since 2015. He was on the 3 medications. His vision was good, but the pressure was extremely high. He also complained of headaches. In 2017, due to his high pressure, intraocular pressure, a micropulse cyclophotocoagulation, both eyes, was done twice. Twice also trabeculoplasty with no effect. So in 2021, in April and May, trabeculectomy with adjustable sutures and mitomycin was performed, and his intraocular pressure dropped to 8 to 10 with no medications. Here is his visual field with quite good pressure in November 2022. In November 2022, visual acuity was reduced to 0.5 and 0.4 with hyperopic shift. So what we decided to do, here is his visual fundus photo photograph, and you can see chorioidal folds due to hypotony, which was also present for hypotony in OCT. So he was scheduled for compression sutures, and the open questions still remained because right now his intraocular pressure is on dexamethasone is 7 to 8. He still has chorioidal folds. So what to do? Another compression sutures to the flap, or how to stop the hypotony and vision loss. The next patient is 55-year-old male who had a trauma in his left eye in 2013, so it was almost more than a decade ago. He had phacovitrectomy done, and since then there is a decentered IOL and post-traumatic mydriasis. His visual acuity in 2022 was 0.4, but in 2023 he complained to decreased visual acuity to 0.1, and when we did the autofluorescent, you can see the macular edema. And here there is an edema in the OCT with subretinal fluid. And we decided to give him triamcinolone, which helped. The vision improved steadily from 0.1 to 0.3. There was a recurrence of this edema in November 2023, so triamcinolone was given again. And after treatment and stabilization of intraocular pressure spikes, the retina looks quite okay. And because this edema is recurrent, and another episode presented as the previous in previous slides was in 2024. So what to do? Shall we remove the decentered IOL with iris reconstruction, or give the triamcinolone again? What are the suggestions? Thank you for your attention.
Okay, dear colleagues, I am grateful for listening and grateful for comments. Dr. Kagampanji, can you address these comments on the audience? Very grateful. I am very grateful personally for them. So can you switch on your microphone?
It's like this. It seems like your cases I had encountered in my past 25 years of practice.
Okay.
Okay.
So can you comment on
All right.
the
First case.
cases?
First
Okay.
case, okay. I have a case right now, presently almost the same. One eye operated with post-vitrectomy, and the other eye, no vitrectomy. The other eye with no vitrectomy, although with uveitis, when treated, the treatment lasts longer. And the eye with vitrectomy is the one that, even though I treat it with steroids and sometimes with other medications and non-steroidal, they improve, but it gets worse also over time. So what I did with my previous experience with during the pandemic, there was no methotrexate in what you call this, in sympathetic ophthalmia, which I will discuss later, is that we use cyclosporine. And this time, I was guided also with a uveitis expert in our country, Johnny Lopez. He told me that I think you continue cyclosporine because everything is doing fine. So what we did, cyclosporine, I think 25 milligrams once a day only for about 2 weeks. And lo and behold, it starts to improve. And then slowly we would taper it. If it's every day, we remove just every week, no cyclosporine every Wednesday.
Okay.
For the next 2 weeks. Then you add again, no cyclosporine on Tuesday and Thursday. For 2 weeks.
So
slowly.
tapering. Okay.
Yes. But you have to monitor the liver enzymes, also, and the CBC, WBC. Now, the problem with timolol is that I had that mistake when I was in residency. I was giving timolol, and some patients, especially in trauma cases, would start having edema. This is one of the effects. So my professor told me, shift to Alphagan, especially post-patient retina. Then, another tip is that wait for 6 months for the right eye before touching. So at least you know everything. And you try to see, I would make a graph, make sure that when the spikes and problems would occur.
Okay, thank you. So you also suggested to close follow-up of the macroaneurysm.
Yes, I also
okay, because you also had it.
Yes,
okay,
I was a beginning retina specialist in my fellowship. I did the same thing. And lo and behold, after a year, patient came with a similar presentation because one, I think it's a macroaneurysm and somehow it doesn't close really, so it can come back. But some would say that you try to laser it. I think in the old, I remember I read it somewhere, maybe you can also use PDT, but then just to make sure it's not on the macula.
Okay.
Now, nice case, I think, in vision helps.
Okay. And optic pit, you suggest also to cover, to go into the eye and cover the pit with the amniotic membrane.
Yes. Because 2 years ago, go ahead. 2 years ago, the EPRS, we used that, right?
Okay. But do you use gas inside for tamponade? Gas. Okay.
Yes.
Which one?
Yes.
Which one?
Okay. Here in the Philippines, we usually C3F8.
C3F8. Okay. And about the hypotony guy from my last presentation, so you will suggest triamcinolone with subtenon, yes?
Okay, what happened? The first part was that I just didn't get it quite. Was it a trabeculectomy or was it a surgical?
Yeah, it was trabeculectomy with sutures, with adjustable sutures, because his pressure was around 50 on 3 medications. We didn't want to wait until the field is closing. And microcyclophotocoagulation did not work, SLT didn't work, so we decided to do trabeculectomy. And this is actually the situation 3 years after trabeculectomy. He started to develop hypotony problems. So that was my question, what to do with him. So compression sutures didn't work. I don't want to suture that filtration fistula, because I am a little bit afraid that everything starts to shift toward the higher pressure. So
All right.
triamcinolone.
Okay. We had the
Okay.
same case with hypotony again. So
Uh-huh.
3 years ago, we operated this
Mhm.
guy, and I think the pressure was
Mhm.
about 60. So we do usually hear a filtering surgery. We make a bleb, but somehow the
Mhm.
inferior part wasn't really getting any better. They were also the same thing. So we just
Mhm.
did the triamcinolone.
Mhm.
Okay. And at the same time, I think he was also started with prednisolone, prednisone
Uh-huh.
tablets, and then every
Uh-huh.
2 weeks we tapered it. The reason is that sometimes if you had your previous treatments done to the eye, the production of the aqueous fluid might still be there or it's well managed, but the ciliary body can have the inflammatory cells coming in.
Reaction. Mhm.
Yeah. So that's why when we do, for example, PPV, when I do a PPV, as much as possible, I try to indent and see the ciliary body if it's covered with this whitish membrane, and I try to remove it
Mhm.
slowly one by one.
Okay. And the last one, the third case, did you have any cytomegalovirus infections? Because for us, it was actually the first patient because she had successful cataract surgery, and all of a sudden she developed this retinitis. And
Yes.
it was a really the problem was that all serologic tests really went negative, and hematologist actually scheduled PCR tests.
Okay.
So,
So,
mhm.
is he sexually active, like an HIV positive?
No, she has multiple myeloma. Because
Oh, so
she
that
is
means
hematology patient suffering from multiple myeloma. In time of cataract surgery, she had a remission of her multiple myeloma, and I don't remember, it was a couple weeks after cataract surgery when the vision started to drop.
okay. I think I would still consider it if it's CMV retinitis. We still treat it the way it's supposed to be, like ganciclovir implant, but I've never done that before. I do get
Mhm.
patients with retinitis because they're HIV positive, but to
Uh-huh.
really do it, because the implants here in the Philippines, it's very, very difficult to get.
Uh-huh.
But
Mhm.
right, so what happens is that maybe in theory, yes, you have to treat first the stem. So maybe do a ganciclovir implant.
We
Because
don't
it's
have
retinitis,
we
correct?
don't have the implants in Poland. That's the problem because they are very
Same here.
expensive, and that's why she is on valacyclovir oral.
Valcyclovir.
First it
Yes.
was ganciclovir and then valacyclovir, but she is getting better, so let's hope for the best. Okay. Any other comments, questions, suggestions? If anything, please feel free and post it. Okay, so I
All
think
right.
we are coming to the end of this discussion, and let's move to. Okay, actually, we can have 5 minutes break because the next session starts in 5 minutes. 11 past 4, so we still have 5 minutes. No, actually 3 minutes.
Well, I have
Okay.
the next one actually, if I may ask, is that I have 3 students who's joining on the next session. They're a little bit curious in how it is in Poland when it comes to like fellowship. Can you
I think if they want to come for fellowship, they shall ask in the university clinics. Because I, for sure, in Lublin, in southeastern Poland, there is a Professor Rejdak University Clinic. He's
Welcome everyone. My name is Klaudia Rakusiewicz-Krasnodębska. I am a pediatric ophthalmologist working at the Children Memorial Health Institute in Warsaw in Poland. And it is my great pleasure to present a case illustrating how low-dose atropine can be effectively used to control myopia in a child with intermittent exotropia, and how combining pharmaceutical, surgical, and optical strategies can provide long-term stability. As is widely known, we are currently witnessing a global epidemic of myopia, mainly due to the increased time children spend in front of screen and the reduced amount of time they spend outdoors. At the same time, early onset myopia and other contributing factors are associated with a growing prevalence of intermittent exotropia. Studies consistently report that the onset of exotropia is closely related to the age of which myopia develops, and intermittent exotropia may occur with various degrees of severity in up to 25% of myopic patients. The 6-year-old boy presented with intermittent outward deviation of the left eye and blurred distance vision with no other significant medical history. On examination, intermittent exotropia with poor control was observed, with a deviation angle of 25 prism diopters at a distance and 25 prism diopters at near. Refraction revealed myopia of -2 diopters in the right eye and -2.25 diopters with -0.5 diopters of astigmatism in the left eye. Based on guidelines published by the World Society of Pediatric Ophthalmology and Strabismus, there is sufficient evidence to warrant the adoption of myopia prevention and control measures in clinical practice in children with progressive myopia of childhood. So, from the first visit, we should introduce and recommend myopia control studies for these patients. As we all know, optical methods such as the focus lenses are not recommended for patients with strabismus or impaired binocular vision. Although preliminary studies suggest that this method doesn't significantly disturb binocular vision, it is still not recommended as the first-line approach for slowing myopia progression in such cases. Considering the degree of refractive error and the child's age, the patient was prescribed 0.01% atropine myo-free eye drops for long-term nightly use as an effective, evidence-based, and safe method to slow myopia progression in patients with strabismus. The patient was monitored over a 12-month period during which no significant progression of myopia was observed based on refractive error measurements and axial length of the eyeball assessments. It should be emphasized that between the age of 6 and 7, the patient's axial eye length increased by only 0.10 millimeters in the right eye and 0.14 millimeters in the left eye, resulting in a refractive error increase of just 0.25 diopters only in the left eye. Due to the indication for surgical treatment of strabismus, the patient underwent surgery for intermittent exotropia. A resection procedure was performed on the left eye. After achieving correct ocular alignment, I also recommended the use of low-dose atropine due to its proven effectiveness. In addition, the focus spectacles may be prescribed to further slow refractive error progression during the child's peak growth period when the greatest myopia progression is expected. The patient was followed for next 1 year after strabismus surgery, and a very good control of myopia progression was observed. Over a 2.5-year period, the refractive error increased symmetrically by 0.5 diopters in both eyes. In conclusion, low-dose atropine is safe in children with intermittent exotropia, and it is an excellent treatment method for patients with strabismus that can be used both before surgery and continued after strabismus surgery. Thank you for your attention, and thank you very much. Thank you for your attention.
Hello everyone. So I will be doing this live. So the title of my topic is the iron eye injury. So this is a case of a 21-year-old male who was hit by a steel pitcher in the left eye. Repair of the left ocular injury was delayed by more than 2 months. Initial medications consisted of tropicamide and polymyxin dexamethasone eye drops. This happened during 2020 Corona times medical care, as we call it. So this case is from the Philippines. The visual acuity of this patient when he was presented to me was in the right eye was 2400. There were cells and flares +2 by slit lamp. Visual acuity was counting fingers at 3 to 4 feet in the left eye. There was an iris prolapse located from 9:30 to 12 o'clock position, superior to the limbus 4 millimeter from the limbus. The bulbar conjunctiva was extremely hyperemic. Medications started with prednisolone, 10 milligrams, 9 tablets for 7 days, atropine sulfate 3 times a day, and combination of antibiotics 4 times a day. And this patient was instructed to have surgical repair immediately. However, patient refused, so surgical repair was delayed. However, patient 1 week after, visual acuity in the right eye again dropped to counting fingers at 3 feet. So patient was just given subtenos injection of triamcinolone in the right eye, and clearance for surgery was finally started. And this is what we can see in the right eye. So the fundoscopic findings, exudative RD on the posterior pole, multiple round subretinal whitish lesions with a dull foveal reflex. This is the fluorescein angiogram. Question, what is the next therapy in this patient? Direct enucleation, photodynamic therapy, corticosteroids, blood wash, or acyclovir? The answer is steroids. So medical treatment concentrated on saving the right eye, and surgical approach is surgical repair to the left eye since it was already delayed for 2 months. And the visual acuity of the right eye was already counting fingers to 3 feet and light perception in the left eye. So treatment is, as we call, Predforte or prednisolone acetate and oral medications of prednisone. 3 weeks after ocular trauma surgery, visual acuity of the right eye improved to 2150. Indirect ophthalmoscopy showed a detached retina superiorly, but the rest are attached. Topical prednisolone was continued, same as antibiotics. Oral prednisolone was continued, vitamin C was continued, acetazolamide of 200 milligrams per kilogram 4 times a day was started because of the spike in the IOP, and cyclosporine was added to the oral medication. And the right eye stabilized as 20/70. Prednisone tablets was slowly tapered, and repeat subtenon triamcinolone injection in the right eye. Vision improved on the 5th month to 20/25 in the right eye. Medications this time is cyclosporine dropped to once a day, every Monday, Wednesday, and Friday, and prednisone was already down to 3 tablets. However, we did some laboratory to watch for WBC and the liver enzymes. The sympathetic ophthalmic pathogenesis. Exact cause is unknown. Pathogenesis autoimmune against an uveal self-antigen. 2, maybe bacterial contaminants as adjuvants enhancing the sensitization. Or the low incidence in filtering surgeries could be due to the presence of transforming growth factor beta in the aqueous, which has an inhibitory property in the immune cells. Autoimmune against an uveal self-antigen. So we have the antigens such as the S antigen, interphotoreceptor binding protein, and rhodopsin from the retina, and extrusion of the uveal tissues and exposure of the uveal antigens to the subconjunctival lymphatics. Bacterial contaminants, adjuvants, enhancing the sensitization. And for the number 3, low incidence in filtering surgeries, could be due to the presence of the transforming growth factor, which is lost in inflamed eyes, and increased risk of sympathetic ophthalmia in the delayed repair of ocular wounds and after repeated surgery. And also, peripheral blood lymphocytes from sympathetic ophthalmia patients demonstrates positive cell-mediated amnestic response antibodies in the serum, predominant T lymphocyte reaction in the injured sympathizing other eye, and anti-retinal antibodies, such as photoreceptor and Müller cells, have been found in a few patients. Fluorescein angiogram shows the degree of posterior disease and multifocal round areas of leakage at the RPE and choroid. Pooling of dye in the late stages observed in patients with serous retinal detachment, and in the early venous phase, early hypofluorescence, then hyperfluorescence in the late stages. Indicating obliteration of capillaries are the presence of Dallen-Fuchs nodules and choroidal granulomata. Diagnostics will also help is OCT and chest X-ray to rule out sarcoidosis in other countries, but for the Philippines, tuberculosis before oral steroid is initiated. B-scan ultrasound will show thickened choroid, ICG similar to VKH, and CBC, RPR, and FDA, ABS for syphilis, and if sarcoidosis is suspected, ACE, ERG and OEG will show severity and guide therapeutic treatments and response. Anterior segment inflammatory findings are Bosaka nodules and Kepi nodules, as well as erratic precipitates. And poor accommodation is a sign of sympathetic ophthalmia. And posterior segments such as vitritis, choroiditis, exudative retinal detachment, and papillitis. As discussed, Dallen-Fuchs nodules can be found on the yellow-white subretinal lesions and goes atrophic over time. So this is the final photo. You can see when the patients are treated. And thank you very much. And also thank you to Janine Villano, my resident, who helped me with this case from the Southern Philippines Medical Center. Thank you very much.
Good day, everyone. I am Dr. Rene Boy Di Costo from Davao Regional Medical Center in Tagum City, Philippines. Welcome to my case presentation entitled, I Like Your Eyes. I have no financial disclosure in this presentation. This is a case of AA, a healthy young 19 years old male from the province of Davao del Norte, Philippines. The patient and his friends saw a black yellow cobra snake creeping in their backyard. As usual community behavior towards seeing any type of snake, they tried to seize and kill it from a 2-meter distance using a long stick. However, Just as the patient approached the snake, it was already threatened and fought back by spitting a liquid venom into his left eye. The patient's friend rushed over and struck the snake with a stick to its demise. This is the photograph of the snake which attacked the patient. The morphology corresponds to the description of local Naja samarensis cobra snake, described as black, bright yellow coloration. The patient experienced immediate, intense burning eye pain of the left eye associated with lacrimation but no blurring of vision. Immediately, he washed his face and eyes with tap water, which afforded pain relief. The patient arrived at the emergency room 6 hours post-envenomation asymptomatic and was cleared by the toxicologist. He was then referred to ophthalmology service. There was no more complaint of eye pain, but there's still eye redness and lacrimation. The visual acuity were normal, and no ptosis was seen. The slit lamp examinations revealed mild blepharoconjunctivitis and diffuse punctate epithelial defects of the left eye. The rest of the ophthalmologic examinations were unremarkable. Right after slit lamp examination, we irrigated the eye with 1 liter of saline solution over 30 minutes to decontaminate the eye, and followed with administration of topical antibiotic and lubricant. The patient was then discharged after being cleared by all emergency services, improved with the topical medications. And antivenom, it was not recommended. Follow-up was done after 24 hours post-envenomation, and there was complete resolution of symptoms, including resolution of corneal epithelial defects without sequelae. Cobra snakes belonging to the family Lapidae are venomous spitting snakes in the world, commonly found in the tropics, including the Philippines. The Philippines is home to 2 venomous spitting cobras, the Naja philippinensis, which is endemic in the northern part of the country, and the Naja samarensis, which is endemic in the eastern and southern part. The 2 species were listed under the WHO Category 1 list of venomous snake in the world. Spitting behavior of cobra is their generous way of defending themselves from their offenders. It is a signal that we should keep away from them or else we will be beaten to death. Spitting cobra incidents are anecdotally common in the rural communities in the tropics, but poorly documented and reported. Africa and some Asian countries like China and Taiwan have several reported cases in the past, but the Philippines has none so far. When a cobra venom is spat into the eyes, it will result to a manifestation called snake venom ophthalmia. Presentations varied from mild to moderate blepharoconjunctivitis to severe uveitis. It can also present as allergic reaction. The most common injury observed is corneal injury, varying from mild superficial punctate erosions to large ulcerations. Blindness, however, can occur as a complication from a poorly managed case, just like these 2 Nigerian cases, which resulted to corneal perforation and endophthalmitis and dense corneal opacity after a neglected injury sustained from an African spitting cobra. To this date, there has been no reported cases yet linking blindness from direct ocular envenomation. So which of the following cobra species produce a more severe form of snake venom ophthalmia? Literature suggested that the African cobra species, Naja nigricollis, seems to produce a more severe form of SVO, manifested in severe conjunctivitis and large corneal ulcers. And among the Asian species, Naja atra and Naja sumatrana produce a moderate clinical course as manifested with small to moderately large corneal ulcers and profound conjunctivitis. So how about our Philippine Samar cobra? From the Toxicon Journal, 2 cases of SVO caused by Samar cobra were earlier reported. Manifestations were only mild burning pain, mild blepharoconjunctivitis with minimal epithelial punctate erosions with complete recovery without sequelae. Our index case patient AA also showed a milder clinical course manifested with moderate burning eye pain, mild blepharoconjunctivitis, presence of punctate corneal epithelial defects that completely resolved without sequelae. This places Nadia samarensis under the milder spectrum of snake venom ophthalmia as compared to its Asian and African counterparts. Proteomic study of summer cobra venom found out that 90% of the venom are three-finger toxin composed of neurotoxins and cytotoxin. These are primarily responsible for its systemic toxicity, but it does not clinically cause ocular damage. The remaining 10% of cobra venom contents are the ones causes the ocular symptoms. The phospholipases A and L amino acid oxidases are responsible for the burning eye pain sensation, and the cysteine-rich secretory protein causes inflammatory and vascular response. The presence of metalloproteinases can also induce inflammation, local tissue toxicity, extracellular matrix breakdown, and epithelial cell loss, leading to punctate epithelial erosions. So which cobra species have more abundant phospholipases and metalloproteinases in their venom? The African and Asian cobra species have more abundant phospholipases and metalloproteinases compared to summer cobra. This explains why summer cobra produces a milder clinical course as compared to its African and Asian counterparts. Experts highly recommend irrigation using tap water, saline, and Ringer's lactate solution as the mainstay decontamination strategy. Water washes away and neutralizes the venom inoculated in the eyes, thereby preventing its local absorption, prevents tissue degradation, and also relieved pain. Topical antibiotic is useful to prevent bacterial co-infection, especially for those irrigated with non-sterile tap water. Since there is no evidence of systemic spread from ocular envenomation, intravenous antivenom is unjustified and risks anaphylaxis. So in case you visit Philippines and spot by a summer cobra, remember that snake venom ophthalmia caused by Nadia samarensis is a mild disease. It is manifested with mild blepharoconjunctivitis and punctate epithelial erosions. It is neither vision nor life-threatening. It is manageable with water irrigation, and antivenom is not recommended. Thank you for your avid attention. This is Rene reminding us all that cobra is our friend, but a friend that we should keep distance from.
Good day everyone, I'm Dr. Marifel Montenegro from De La Salle University Medical Center, Philippines, to present a case entitled Golden Glow, a Silent Blow. To start, the patient is an 8-year-old female, MSM Filipino from Cavite, Philippines, who presented to our institution with bilateral blurring of vision. The history begins a 4-month history of blurred vision, noticed as visual disturbance at school, leading to poor performance. She was observed to open her eyes widely to focus, with no other associated symptoms. She later developed intermittent headaches. Despite this, she continued attending school until she was seen by a private ophthalmologist and was diagnosed with retinal pathology and was referred to our institution. A review of her birth and perinatal history was unremarkable. Her past ocular and medical history were negative. Review of systems was conducted. The only positive sign and finding were headache, blurring of vision, and poor activity. At presentation, the patient was clinically stable. She was awake, alert, and oriented with stable vital signs. Proceeding to our primary investigation, the initial ocular findings showed that there's a profound bilateral visual impairment of 2200 in both eyes, which failed to improve with pinhole and refraction. Anterior segment slit lamp exam was completely silent. At this initial exam, her pupils were briskly reactive with no REPD, her EOMs were full, and the pathology was clearly not in the front of the eye. However, fundoscopy revealed a dramatic bilateral picture, indistinct disc borders, significant optic disc swelling, tortoise vessels, diffuse flame-shaped hemorrhages, and extensive exudates. It looked like Coats-like retinopathy, but it was bilateral, which is an important red flag. These findings demanded an immediate interdisciplinary investigation, and yet your exam was completely normal. Cerebellar function, meningeal signs, and motor and sensory systems were all intact, and at this point we had ocular swelling without systemic or neurologic abnormalities. The working diagnosis was broad congenital retinopathy, possibly Coats-like retinopathy, and the plan was to refer the patient to pediatrics for full systemic workup. The patient was managed in coordination with multiple services, and the case narrative now hinges on the progressive ocular findings in the face of ongoing systemic treatment. This presents a clinical decision point. In a child with bilateral exudates and no ocular inflammation, what should be the next step? Answer is C. Evaluate for systemic or infectious causes. And indeed, the pediatric workup was immediately fruitful and covered 3 active systemic infections: pneumonia, a parasitic infection, and a UTI. All 3 were promptly treated and all 3 resolved. This should have been the end of the case, but it was not. Instead, we encountered a profound divergence in the evidence. Those infections turned out to be diagnostic red herrings. The child's fever resolved and appetite slightly improved, yet her vision worsened and experienced vomiting, revealing that the real disease was still hidden. Our focus shifted and a crucial new finding emerged. This was the case's turning point. The patient was lost to follow-up. However, on return, she had an RAPD and esotropia. The silent blow made audible. This confirmed optic nerve dysfunction, leading us to consider neuroretinitis versus papilledema, and we requested an MRI. Her follow-up fundus showed progression with worsening exudates, edema, and retinal detachment, confirming an active assault. The OCT scans quantified this, showing massive serous retinal detachment and diffuse subretinal fluid in both eyes. A definitive neuroocular process was evident, but the cause remained unclear. Comprehensive panels were performed, yet all returned negative, deepening the diagnostic mystery. At this point, we proceeded with advanced imaging to assess the unexplained inflammatory process. The MRI marked the turning point. These findings confirm an active intracranial inflammatory process and tied the evidence together. MRI showed bilateral optic nerve enhancement, cerebellar inflammation, and hydrocephalus. All of the following conditions may be present with such findings, except answer is C. Idiopathic intracranial hypertension. So this finding is clarified by our next question. What feature here favors CNS TB over idiopathic intracranial hypertension? So answer is parenchymal or meningeal enhancement. So at this point, we consider the greatest masquerader, CNS TB, which is an infection of the meninges or brain parenchyma by Mycobacterium tuberculosis. According to WHO, it occurs in 5 to 10% of extrapulmonary TB cases, which often strikes children in endemic areas like Southeast Asia and Sub-Saharan Africa. It presents in many disguises. It can be meningitis, tuberculoma, abscess, and in this case, it began as blurred vision. In CNS TB, inflammation or tuberculoma obstructs CSF flow, increasing ICP, wherein meningeal swelling compresses the optic nerve, leading to disc edema, and prolonged pressure results in optic atrophy and field loss. Diagnosis of CNS is based on MRI, CSF findings, and labs to confirm the diagnosis. So, clinical presentation includes visual disturbances, headache, and nausea and vomiting. For the treatment, we can give anti-COX, corticosteroids, and VP shunt for hydrocephalus. Here, timing is everything. The earlier the recognition, the greater the recovery. With this final piece of evidence, all of the clinical contraindications were resolved. We could now form a single unifying diagnosis. Connecting the evidence, the headache, dizziness came from hydrocephalus, the golden glow from exudative retinal, and the silent blow, the RAPD, from the optic nerve involvement. Together, this pointed to a single diagnosis, which was a final diagnosis, CNS tuberculosis with ocular involvement. This is a classic masquerade syndrome. We validated this difficult diagnosis using the Marais criteria, which the patient met for probable CNS tuberculosis. The resolution was comprehensive. The patient was started on anti-COX and corticosteroids, and a VP shunt was planned to manage the hydrocephalus. The outcome is systemic recovery. Thank you.
Good day, everyone. I am Ramon Ilu Jr. from the De La Salle University Medical Center, and today I will be presenting a case entitled Lid Off Mystery, a systemic approach from diagnosis to staging. Today I will be presenting a 75-year-old woman with the upper left lid mass initially managed as presumed chalazion. So, here is our subject, a 75-year-old female with several comorbidities. Most notably for our investigation, she has a prior oncologic history. The initial report was simple, a persistent nodule, clinically suspected to be a benign cyst. A routine excision was then performed. On examination, everything was localized to the lid. No lash loss, no ulceration, no fixation. So nothing that forced me to abandon the initial chalazion impression at that point. I'll put this into the room. Based on a slow localized non-tender lid nodule and the benign appearing on examination, what would you call it before pathology? My pre-pathologic working diagnosis is chalazion, which is reasonable during your time, but non-resolved typical issues must go to histology. That's exactly what happened here. This was the standard minor procedure for a presumed chalazion. Excision, rectal closure, and the specimen sense pathology. This is where the case turned. The initial pathology report was not a benign cyst. The diagnosis was a rare malignancy, endocrine mucin-producing sweat gland carcinoma. And here is our first major complication. The tumor was at ink margin. The case was not closed. This left us with two critical unanswered questions. So the biopsy has given us this very rare diagnosis, an endocrine mucin-producing sweat gland carcinoma. So what exactly is this? This is an extremely rare, low-grade, or indolent adnexal The main clinical challenge, and the central problem in our case, is its risk of local recurrence, especially as the report indicates when the tumor margins. Now let's look at the pathology to see how this diagnosis was confirmed. Looking at the left image and addressing our first research question, what is this rare tumor? We went back to the microscope and the H&E gives us our first clues. At low power, we see organized nested lobules. But at high power, as you can see on the right image, the puzzle becomes clearer. Look at this monotonous round cells with that classic stippled salt and pepper chromatin. This morphology is a strong clue, pointing directly to its neuroendocrine in origin. But in an investigation, suspicion is not enough. We need definitive fingerprint. So looking at this IHC panel, this is the definitive fingerprint that we're looking for. The IHC panel. The tumor clearly suggests positive for both synaptophysin and chromogranin. This is what confirms its neuroendocrine identity. It's ER positive and P63 negative, which is the classic signature of our lesion. So the puzzle number 1 is solved. We know exactly what this is. But this opens our second question, the more urgent one. We know what it is, but we need to know where it is. We have positive margins, so the question now is, has it spread? We have expanded the investigation to do a full body PET CT scan. The results were our second brick in this case. Despite the positive margins, there was no metabolically active tumor at the primary site, and no evidence of metastatic disease anywhere. This is the best case scenario. So let's solve the case. We started with a simple cyst. The first anomaly was then sent to the pathology, a rare malignancy with positive margins. Our investigation followed the clues. The H&E suggested it's neuroendocrine tumor, and the IHC confirmed it. And finally, looking back at the PET CT, it finally staged it, revealing no evidence of the disease. We have now successfully identified and staged this tumor. With positive margins, the question is how to re-excise while ensuring clearance. My priority is oncologic clearance with controlled margins, most surgery if available. Otherwise, stage excision with reliable margin assessment, then reconstruction. This brings us to our final disposition. You will immediately notice an important contradiction. Our quiz question correctly identified the textbook's best next step as wide local excision with margin control. However, our final plan for this patient was active surveillance, with no immediate re-excision indicated. This is the central point of our systemic approach. This decision was not made lightly and was based on a multidisciplinary discussion balancing three key factors. First, the tumor biology. As we discussed, this is a very low-grade, indolent tumor. The risk of rapid and local recurrence or metastasis is very low. Second, the staging results. The positron emission tomography scan was crucial. It showed no discernible hypermetabolic mass at the primary site and, most importantly, no evidence of any regional or distant metastatic disease. This gives us the confidence that the positive margin represents, at worst, a microscopic non-avid focus of residual disease. Third and lastly, as well as the most important, the patient factors. Our patient is a 75-year-old with significant comorbidities, including uncontrolled type 2 diabetes and hypertension. A second wider excision would not be a simple procedure. It would likely require a complex upper lid reconstructions, which carry significant surgical, anesthetic, and wound healing risks for her. Therefore, after balancing the high surgical risk of the patient against the low biological risk of the tumor, the team concluded that the immediate high-risk surgery was not in the patient's best interest. We opted for a plan of close, active surveillance. My take-home is simple. Don't dismiss persistent lid lesions. Let margins lead the plan, lock in the diagnosis with the right IHC, clear the tumor, then rebuild. This concludes my presentation. I appreciate everyone's time and attention. Thank you very much.
Minutes more or less for discussion. We can discuss case by case. Some, let's say, questions were raised on the chat, but I think we need to repeat them for everybody following the conference. So let's start with the first talk on atropine. And there was I hope that Dr. Who presented this talk is still with us. At least we can have a short discussion on atropine. The question was about the sensitivity to low-dose atropine or effectiveness in non-Asian population, that it was shown that generally non-Asians, they react less than Asians to low-dose atropine. So this was the question. And I can add that I do not see if Dr. Claudia.
Yes, of course I am. So, Professor, yes, thank you very much for your interest in my presentation, and of course, as well as for your comment and question about 0.01% atropine. And of course, you are absolutely right that there is evidence suggesting that 0.01% atropine may be less effective in non-Asia population. And of course, the effectiveness of atropine, depending on its concentration, is a very broad topic, and I think that you agree with me. And however, even a minimal increase in axial length at this age is significant. So controlling regard to my case grow to 0.1 to 0.14 millimeters is a very good result, in my opinion. And we know that higher concentration of atropine are generally more effective, but carry a higher risk of side effect, of course. And we know that in Poland, currently only 0.01% atropine is currently registered So why why higher concentration are available only through special orders, which is why I choose this dose. And importantly, according to the guidelines published by the World Society of Pediatric Ophthalmology and Strabismus, 0.1% atropine may be sufficient when we combined with other myopia control methods, whereas higher concentration should be considered if we used as a lone therapy. So this is my statement.
Thank you so much. I can add that just recently, I mean this month, our meta-analysis on this subject and the systemic review and meta-analysis was published in British Journal of Ophthalmology. For those of you who would like to learn more about the, let's say, ethnical differences related to atropine. I mean, this is the very recent study on that. Okay, thank you so much. And then we need to move on to other cases. And then we have a group of very interesting cases from Philippines. As a matter of fact, I believe that if not all, majority of them deserve to be published in Ophthalmologist. This is the message to Dr. Perfecto, because he's a great patron for all of you. So please move on, prepare it. I would be happy to support. But we have some questions to the different cases. So yes, please. Agnieszka, Perfecto.
I wanted to know about the recurrent erosions after cobra attacks, because the films you showed us was very scary, and if something which is toxic goes with under pressure into the eye, is really scary. So any comments on that, because it's very unusual for us. Okay, so any recurrent erosions, any concerns we should know about?
Hi, good evening. This is just one of my 9 cases of snake vein ophthalmia. In the past 9 months, I had actually 9 cases already. And I have this opportunity to monitor all these patients. And so far, I have not experienced, or these patients did not complain of any recurrent symptoms of recurrent epithelial erosions. And on my slit lamp examinations, there were none so far. And I guess because of the mild presentation of the snake vein ophthalmia caused by our local summer cobra species, it's actually because of this lower abundance of metalloproteinases and phospholipases as compared to the Asian and African.
Okay, thank you. And there was also a question here about the OCT, anterior OCT, for comparing if there is any thinning of the cornea after such contact.
I think we don't see the need of doing OCT anymore, since on follow-up examination, the slit lamp examination is already enough in assessing whether there was melting, there was thinning of the affected cornea. So we did not consider doing OCT anymore.
Okay, thank you.
Perfecto, you are muted.
Is that, for example, if this paper is to be published, there has to be some sort of a record, maybe, so that to prove the point that there is no erosion. So that's just the point that I'm trying to drive at. So even though you think that there's no need, you have to think in a scientific and clinical aspect for publications. And this is going to be already, you told us you have 9 cases, then even just get about 5 of that, complete it. At least it's very scientific. And who knows, you can bring that to ever. The president is already in front of you.
Yeah, welcome you to visit
Okay.
next year, of course. Yeah.
Okay.
So I call them one by one of these days. Just
You
give
have
the
to do
OCT.
it.
Okay.
Thank you.
Okay, we need to move on to the
Yes.
next. Thank you, Dr. De Costa from Davao, the place I have visited already 2 times, so I have my personal, let's say, memories from Davao, of course, as from all Philippines. And then we can move to the next case is by Dr. Montenegro. Very dramatic case, yeah, but very, very, very interesting of this CNS tuberculosis. The question was, what was the final outcome? Is Dr. Montenegro? Yeah, you are with us. Yeah, I can see you now.
Good day, doctor. So for the patient, actually the patient is already at another hospital in the province. But when I asked the relative, unfortunately the vision just slightly improved, but the systemic problems of the patient had improved after giving the anti-cox medication. So the patient was given HRZE for 2 months and another medication, 10 months of isoniazid and rifampicin. So currently, previously the patient was slightly malnourished at around, I think, 25 kilos, but now the patient is already at 35 kilos already. So that's I think for the relatives, the patient had slightly improved systematically.
What about the eye?
It just improved slight visual acuity just improved from when we last saw the patient. It was at counting fingers at around 1, and now the patient is already at 2200 again. Yeah.
Okay.
Perfect.
Can I add something? Okay. I have a similar case, also a patient, 34-year-old mother with tuberculosis, and he has been with me for the past 3 years. The thing is this, if you have TB, tuberculosis in the brain, so what you should do is that every small incremental improvements in vision, you have to think long term. It is not a sprint as far as treatment is concerned. It is a marathon. And for this lady, I think she's not the only one they had. I think I already had 3. The problem is that I was not into research when I started, so I don't have the other 2. So for Dr. Montenegro, just follow up and just keep on going for this case, so the vision can still improve, I think, and monitor it with visual fields.
Mhm.
Okay.
Yeah, good point. Thank you. Agnieszka, do you want to add anything or ask?
No, I just wanted to point the same, that this is the marathon, because normally the lung tuberculosis is half a year of treatment or even more, and if it's a brain tuberculosis, which we personally do not have a lot of cases, this will last more than 1 year, I think. But we all agree that this is the marathon. That's it.
Yeah,
Mhm.
I agree. Thank you. Now we move to the last case by Dr. Lu. And any questions or comments regarding this case?
Okay.
I'm checking the chat, if there is anything on the chat.
Okay. There's none in the chat, but
Okay.
I think Dr. Lu, okay. How's the patient doing now?
Good evening, everyone. Good morning.
Morning.
Currently, we're still closely monitoring the patient as of the moment, and since from what I've stated earlier in my presentation, since the patient is closely on follow-up, currently the tumor is localized, and since it's CMPGC, and basing it on the patient's best interest, currently it's localized, and so far the patient's doing good. The visual acuity is not affected. The tumor is localized, as well as it's not growing. The size is consistent. And currently, the patient's being managed multidisciplinarily, so not only ophtha-wise, but as well as internal medicine-wise and other department. And as for the patient's best interest, the patient's clinically stable right now, sir.
The reason I ask it because should you monitor it, for example, for the next 5 years, and if there's no recurrent, you can say that okay, see me again after 5 years. Do you have like a
Currently,
plan already?
since basically this tumor is actually rare in our country, it's actually ideal to monitor the patient at least every year compared to 5 years, sir. And then as for the patient, since the tumor is not growing, we shouldn't be complacent about it. And as of this moment, the patient's tumor mass is consistent. So far we're happy with the results. So ophtha-wise, we felt like we did what we should, and we just have to monitor the patient consistently. Yes, sir.
And also because if you say it's rare, the more that you should monitor it.
Exactly, sir.
Thank you. Unfortunately, of course, we could continue the discussion. We need to finish both the session and the conference. So I would like to thank so much all the speakers for the great presentations, and our co-moderators, Agnieszka Kardaszewska and Prefect Campaign. And well, just to confirm that we can rely on our Filipinian colleagues within this conference for a long time. So hopefully we will have you next year, and maybe we will have the even a Filipinian, let's say, meeting in the future. Maybe we can do that.
Yes, here in the Philippines, why not? And of course, our co-moderator Agnieszka, why not?
Thank you.
Let's think about
Thank
that.
you.
Thank you so much. Thank you. Bye bye.
Thank you. Have a good evening. Bye bye.
Bye bye.